Hi, everybody. Thank you for joining us. Dr. Anne Sylvestre here, speaking with Dr. Nancy Brock. Nancy is a board-certified anesthesiologist, and she is actually working remotely today from home, where she does help to monitor a lot of patients under anesthesia and helps out the anesthetic team in the remote location to make sure that all goes smoothly in the OR. So welcome, Nancy. Thank you for joining us today.
Thank you. Thank you.
So we've had a few discussions in the past, but I have a question that keeps on coming up, and that is, what's your thought on regional blocks? Where do they fit in the general anesthetic protocol?
I am extremely in favor of incorporating regional anesthesia into an overall anesthesia protocol. And it's partly because I can think back to my career and when I began myself to embrace the application of local anesthesia to numb surgical pain, it dramatically changed the way I approached anesthesia. I can think about kind of a line in the sand. You know, my anesthesia management prior to the use of local, and then my anesthesia management after I embraced it and became confident and capable. And the two main measurable observations for me to show me that I was doing a good thing was the speed at which my patients returned to as close to normal function as one can after a surgical intervention.
Right.
But eating, for instance, would be something that a patient that's maybe non-ambulatory would still be able to do. So the speed at which they become interested in food and they want to eat it's much more rapid. So the time from extubation to eating, and then the quiet, calm nature of the return to consciousness, because the locals that we use last for hours. I'm a huge fan of using bupivacaine just about anywhere, and so that drug gives me 3 to 8 hours of duration of effect, and when it wears off, it doesn't suddenly disappear. If you think about the way sensation comes back to your jaw after some numbing from the dentist, right? It's not all of a sudden I can feel everything. It's this gradual return of sensation, which subjectively I think is more manageable psychologically for us and for the animals. That pain that does come back is much more amenable to low levels of painkillers for briefer periods of time. And then, of course, what comes to mind when we talk about this is drug side effects. The fact that if you're giving a systemic analgesic, then you're going to have systemic effects. They're going to be unavoidable, because when you administer the drug, it's a package deal, right? You get what you want, and then you get things that you don't want. That's managed by lowering doses, oftentimes, which you can do because the pain you're trying to chase is at a much, I shouldn't even use the term chase. You're not chasing pain. Because you've used local anesthesia, you're staying ahead of it, which is also what makes you very efficient. And clients more often than not will give feedback, unrequested feedback, about the level of comfort that they're witnessing in the animals and how a relief it is for them to see that. Comments being made after a dental procedure, for instance, where the client will say, it doesn't appear to me as if anything's been done. Obviously, they're not looking in the mouth. They're just looking at a patient that is back to its normal self, despite the fact that major surgery has been done. And that's music to my ears.
Yeah.
So every surgical procedure is an opportunity to apply regional anesthesia.
We're not making a broad statement here or anything.
No,
like that.
well,
that's what it is. I like that. And you use the word regional anesthesia as opposed to a regional block. So I think you're making a point. We're not necessarily always talking about blocking a specific nerve like the femoral. Am I correct in
sometimes we do. And sometimes, so yes, you could divide regional blocks or local anesthesia into two broad categories. One is an approach to local anesthesia that targets a specific nerve that you know about. You know exactly where it is, and you go and you deposit your local anesthetic around that nerve. And then, so that would be like a femoral block. At the dental nerve blocks, you're going after specific nerves. But then if you look at a laparotomy incision or incision blocks for neuters, you're not blocking specific nerves. You're applying local anesthetic to a broader area to blunt innervation over a large area, but you're not targeting nerves that you know of anatomically as nerves. Right. And so that's, I think about those two categories because I approach them a little bit differently. And infiltrating a surgical site is the low-hanging fruit. For somebody who's skeptical about what I'm saying, to start infiltrating a surgical site with a local anesthetic and then witnessing for themselves qualitatively the impact that has on the patient in recovery.
So let's take a spay, a Chihuahua. I'm just going to make it a small dog spay. How would you suggest that the practitioner proceed with that? Is it an infiltration before making the incision? Afterwards, is it a splash of the regional local anesthetic? How do you do it?
Well, I'm an advocate of putting the local anesthetic at the point where the incision is going to happen.
Okay.
But it's not a deal breaker if a surgeon like yourself says, I just don't like all this swelling where I'm going to make my cut. Okay, no big deal. You do your surgical procedure, and then you've got this nice suture line that tells you exactly where you need to put your local, and then you apply your local on either side of your sutures so that the local anesthetic liquid will diffuse towards your incision, and then everybody's happy. You've got the analgesia that you want in recovery, and you've got a happy surgeon. Now let's take that Chihuahua and let's make it a C-section.
Yeah.
Okay, so now I would say you really should put the local in before, because now you've got.
And I can appreciate that. Yeah.
you've got probably you have a bigger incision. You've got more tissue manipulation, but you also have, for the patient's sake, a desire to reduce the need for high doses of anything that you're going to administer. And so by numbing your surgical site with your local, you now can keep your patient at a lighter plane of anesthesia, which keeps the mom happy and hopefully keeps the puppies also happy.
I like that. That makes it a happy story altogether.
So it's very maneuverable. You can just ask yourself what my goal is, what my patient needs, and then navigate
from there. I love it. I love it. And you're right. That makes it easy to think about, and a good way to decrease the amount of drugs that you may have to need to use.
But it'll be something you can delegate also. We talked about the anesthesia team.
Right.
So once the veterinarian has bought into this as something to add, as a layer of part of the protocol,
right.
That the veterinarian instructs the prep team to infiltrate the surgical site, and then with some training, the anesthesia team knows how to administer the local and does so in the prep area, and the surgeon is freed up to do something else.
Like have a cup of coffee.
Or make some phone calls.
That's what my team always.
Or get into the OR and get your instruments
and get ready, especially in the case of that C-section, right?
Yeah.
I like to be there waiting for my patient to enter the OR. Don't let the patient wait on me. That is wonderful information. Thank you very much for that, Nancy.
Welcome.
Always a pleasure to speak with you.
Same here.